So at that point, I'm going to stop sharing and I'll hand this over to Dr. Mayo. Thank you for your attention.
Okay, so welcome. And you've seen two excellent talks covering a tremendous amount of territory this morning. And now I'm going to try to include in one talk, actually three separate topics. I'm going to briefly review the radiology, talk about approach choice again, since we really haven't had much choice in the previous two segments, and then very briefly some technical aspects. So we're going to go over the fracture morphology and imaging briefly, then a focus on reduction strategies through the iliolinguinal. And I think, for the remainder of this talk, you can, depending on your experience, you can substitute AIP plus a iliofemoral equivalent for a lateral approach for this. I'm going to focus on the posterior column, although DS has already seen it, so we can limit the duplication to some extent. And then I've inverted the order a bit so we can then talk about the patterns where this approach choice is no longer useful because of inaccessibility of some of the components. So I think this is a great example of being lost in translation. So this was the original description of the associated both column. I bet I read this 30 times and I could never figure it out. But ultimately, you've already seen it depicted, and this is a situation where clearly the picture is well worth more than 1,000 words. So there's no articular surface in continuity with the intact posterior nominate bone. And so if we look at the distinction between the last patterns that DS went through, the associated anterior posterior hemitransverse components, this component can become vanishingly small, and eventually, and sometimes it will be incompletely fractured at this point, and then becomes a question of semantics, whether that transitional pattern belongs here or with the both column pattern. This is the more typical, fortunately for us, because it's technically somewhat easier to deal with, the associated both column with extension to the iliac crest, with or without a segmental anterior column component. And Emil made a big distinction between this and the next group. So in this series, it was about 23% of his fractures were associated both column, and the bulk of those 20% were fractures that extended to the crest. There are, however, variants that don't make it that far, and these are much more difficult in general to deal with. So there's one pattern here that exits at the interspinous notch. But you'll see a commonality in some of these. The posterior column component for many of these is relatively axially oriented. And that's important as we come to addressing that later on. And then there are problematic patterns in which the caudal portion of the sacroiliac joint with a variable piece of the upper portion of the posterior column is involved. And these are things that we can't see from an anterior approach and therefore become problematic. And then there are other atypical variants. These are very unusual. This is one in which the posterior column actually carries with it a small segment of the anterior horn of the acetabulum. And these are more curiosities than routine, but we do know how to deal with them. And then lastly, we have to remember that a significant percentage of these fractures have a posterior wall component, more typically more extensive like this, with a communication to the anterior portion of the medius pillar. And these are generally, fortunately for us, relatively minimally displaced, and because of the intact labrum in small displacement, both column fractures, we have a rim held together, and if we get there early enough and we push the anterior and posterior columns back laterally, frequently we can ignore those. But this represented about 15% of Emil series. It's been as high as 25% in other reported series. Looking at the plane radiography, we've already been through these landmarks and we need to remember them. I think it's a useful exercise still not to go directly to your 3D reconstructions, to try to teach yourself innominate osteology on the basis of the landmarks that you're going to use for the most part intraoperatively with fluoroscopy. So the distinction here is that all primary landmarks are either interrupted or displaced, or both. More subtle displacements in this one can sometimes be difficult to see. So we have our posterior wall, anterior wall disruptions. Then we have the ilioscule line and iliopectineal line disruption, at least at one point. We have a displaced roof. And if we weren't sure about that, we might actually have to measure the distance from the midline to where that hip center is in its relationship to the roof. And then lastly, we can still see a teardrop, but its morphology may be different on the opposite side. And that may be different because the components of the teardrop have actually been separated, or it may purely be on a rotational basis alone. So these are the standard things that we can see. And then in this case, because of medialization of the head with the anterior and posterior columns, we can see more of the fracture pattern extending up to the iliac crest. So if we go through that exercise, and all of these will have a similar distribution. We have anterior posterior wall disruptions. We have an ilioscule line, which we can't see, a very high disruption of the iliopectineal line, and a similar pattern for the anterior column disruption. We also see in this situation a bit of widening of the anterior aspect of the sacroiliac joint. The obturator oblique shows this. There's a disruption in the obturator frame, and it frequently doesn't show much separation between the anterior and posterior columns. And that again has to do with the fact that we have a hinge around the periphery, which is essentially holding them together. And then in this case, we can see the so-called spur sign, which is an en face view of the intact innominate bone. If we look at that again, usually seen on the obturator oblique, it doesn't really make any difference what you call this, but frequently you can see the spur sign on the AP. It may not be the same projection, but here we can see that this is an intact innominate bone. And you can actually see it on all three views, depending on the relative displacements of the components of the fracture. And then the iliac projection showing a nice depiction of the exit at the iliac crest. And in this situation, we have an intact lesser sciatic notch and an intact greater sciatic notch. We have anterior posterior walls which are disrupted, and this is our recessed posterior wall. And so this is an atypical situation in which the posterior column has exited very cranially and taken with it a portion of the sciatic buttress. These are George Russell's labels, but it's an important reminder that, as DS already showed you, you have to start at the top and follow it all the way down. So you have the anterior column at the top, the intact innominate bone getting progressively smaller, and then we're picking up the posterior column as we get more caudal. And usually the first thing we see in these with displacements is the quadrilateral surface component of the posterior column, and then we'll follow that down further and further to the point that at this point we almost have nothing left of the intact innominate bone. And many people, without looking very carefully at these, will look at this component, not necessarily at this level, but lower down, and think that there is a posterior wall component. And then all the way down till we get to the anterior column below the roof. Going on to 3D, this is where everybody wants to go. You'll have variable qualities based on the software and the imaging algorithms, but this again shows us that very high exit, taking with it the sciatic buttress. This has its own potential liabilities associated with its fracture pattern in relationship, in this case, to the L5 nerve root, as well as if it's a little bit lower, exiting in the greater sciatic notch, potential injury to the superior gluteal neurovascular bundle. And then the posterior aspect of that, and then the equivalent of an obturator showing the spur sign. I'm not going to spend much time on the anterior column reduction components, which you've already seen. This is based on either using, well, it will be predominantly based on the access that you have through an ilio-inguinal. This is our fracture pattern with an intercalary iliac crest component and this very important pelvic brim component, which sometimes people feel is irrelevant, but is a critical part of your anterior column reduction. The first thing you have to remember is that's your initial displacement. That's where you want to start with lateral traction, usually distal lateral traction. And you're taking advantage of the ligamentaxis component of essentially early reduction by virtue of the fact that the capsule is intact, as is the labrum, at least in small displacement or medium displacement fracture patterns. You've already seen this. I'm not going to belabor it. This is the atypical group of fractures that are articular where we never see the joint. So we're building from the periphery to the joint, and so that any very small peripheral malreduction will tend to amplify as you get closer to the joint. So you've already seen this and ways to avoid it, but it's absolutely critical that before you go any further, that you have this reduction absolutely anatomic, with or without plates or screws. The screws may be lagged or position screws depending on the obliquity. So now we go to this part which I always felt was very difficult for me to reconcile, and that we looked at indications previously. Nobody ever talked about doing a posterior column fracture from an anterior approach, and yet this has become the default option. And it has expanded historically from relatively smaller numbers. A lot in the early going, there were more sequential approaches in Letournel series, but we found that we could actually get away with management of the posterior column from an anterior approach. So you have to learn to deal with that kind of cognitive dissonance. And the thing that allows us to do that is remembering that we have lateral traction, which is taking care of, to a large extent, the rotational deformity here. So if we can compress here and we have an axilla here, then we have an inherently stable pattern in which we can put ultimately screws that don't have to be perpendicular to the fracture and can still generate energy and compression. So this is my favorite initial clamp, since I always use the medial window as essentially an endopelvic equivalent. So a small drill hole here, and then a pointed clamp, and this is again through the medial window. Still one of my favorite maneuvers. You can use the quad clamps, and this is usually through the second window. The spanning ability to go around the psoas from the first to the second is virtually non-existent except in a really atrophic patient with no psoas bulk. You can use this asymmetric. It's really not a clamp, it's a reduction aid. It can act as a clamp because of the soft tissue support of the arms, and that is in this position. So if there is residual medial rotation, this is a very good derotational aid, and it can give you essentially a perfect reduction, and you can assess that through 2 or 3 windows. And this is the lateral portion through the interspinous notch, so you have to make a small window for the lateral arm. And then if you don't like the fact that it may be slightly posteriorly displaced, then you can judiciously place a bone hook in the lesser sciatic notch. And that will allow you to then bring the posterior column anterior as you lateralize. This is the collinear clamp, which is extremely powerful, but is not a very good manipulation aid, i.e. it can compress, but it's not very good at actually manipulating what you're compressing. The danger here is that if you compress too much here, and what you can see, you always have to be worried about what's happening on the side opposite you, which will be a gap the more tension you generate on the quadrilateral surface. So those are the primary means of dealing with the posterior column. And this clamp is usually placed through the first window with a hip flex. It actually acts as its own retractor, as does the asymmetric clamp. It can also be placed to the second window with care. So what about the fixation? We've already talked about the orientation of the posterior column in a lot of these patterns being relatively axially rather than oblique sagittal in orientation, unlike the associated anterior posterior hemitransverse. So we know that our posterior screws beginning in the anesthetic buttress are going to be safe. And we just have to figure out how we're going to minimize the lateral or retroacetabular gap, which we know exists, but we can't see. And so our first screw is designed to come out in this position, the retroacetabular surface. And because of this buttress effect here, because we've already fixed the innominate bone here, even though this screw is not perpendicular to the fracture, if it's loaded, it can generate some compression and it can't go anywhere because of this fixation. So that screw goes in first, and then we have to think about where else we can put screws. And DS has already shown you that a line from the SI joint to the psoas gutter essentially demarcates no man's land as far as screws that don't exit on the quadrilateral surface. So we have the head here, we have these potential screws. This we know if we're going to use it, it's going to go through the cotyloid fossa. And other than that, we're going to be dealing with oblique screw orientation. So we've had our first screw already placed. So now the second screw is this one, which is usually much longer. And since we've neutralized the lateral gap, hopefully we can make this as long as we want. And indeed, it usually comes down in the ischial spine. It can be 110 to 120 millimeters. And at that point, we've then fixed the posterior column to the anterior column. And we just have to decide whether or not this is significant. In many cases, this is low enough, it's almost extra-articular, and I would ignore it. But you can fix it after you've finished in situ plate contouring. There are a variety of ways to do this. Using just simple 4.5 millimeter screwdrivers or dedicated instrumentation. So you can fix that and then do your final fixation in the pubic body. And DS has already shown you the screw. This is the location that Emil talked about, which is going through the cotyloid fossa. So you usually have your finger on the obturator neurovascular bundle as you're putting the screw in. And this is going through the fossa. It can also be moved over here and becomes in, out, in. But remember, the out part is right in the obturator canal, or the obturator canal, not the obturator frame. The canal is what's holding the neurovascular bundle. So that's a dangerous potential place to put it. It also is difficult to get back in because this is a cortical surface that can sometimes make it difficult, even after you've drilled it, to have the screw find it. And that's where it would be if it goes through the cotyloid fossa, and you have to make sure you can image that they're fully clear of the articular surface. Lastly, what do you do with the posterior wall? Progressively, we've just dealt with these from a limited, but hopefully adequate exposure of the lateral aspect of the ilium to put a clamp outside. And if we've done a really good job of reducing the columns, then the posterior wall will be minimally displaced. And sometimes we can just fix it in situ, or we can clamp it and then fix it from inside out. So what about the limitations of the fracture pattern? Well, we know that the more iliac comminution or posterior extension that it is, the more likely we are going to build in a secondary congruence. Even if our fracture planes that we're seeing look good, eventually we end up with problems of essentially reforming the joint around the head rather than creating an anatomic construct. In situations in which the B-type or the exit of the anterior column is below the crest, these become progressively more complicated. And in cases in which there's articular comminution, even more so. And then there are occasional segmental posterior column fractures, which are very difficult to deal with from the front. And then we've seen this already, the inaccessible caudal portion of the sacroiliac joint, which provides a key component of our articular reduction sequence. And then lastly, what about the atypical, more displaced posterior wall components? The alternatives after the default iliolinguinal are the extended iliofemoral, which Mike Stover is going to talk about shortly, and then sequential approaches, typically iliolinguinal followed by a Coker-Langenbeck. And in the early days, there were some Cokers followed by iliolinguinal. And then Jeff Mass, extended iliolinguinal, we'll see one case of that, and that's the citation that you see below. I'm just going to go through what has sort of followed as far as we've expanded the indications for this. So these are relatively fuzzy volume rendered images of a both column fracture in which the cranial portion of the SI joint is involved. We can follow this through when we see the obturator oblique view. And then we can see this segmental component of the sacroiliac joint, but now this is the stable part, and this is part of our visualized field. And you can see this immediately set up for a potential lag screw fixation. And then in 3Ds, we have the very posterior extent of that component. We have a fairly typical variant of a posterior wall, and then this, again, anterior segmental component of the fracture pattern with some pelvic brim comminution to make it a little more interesting, and then some displacement of the quadrilateral surface. We've already hit that point multiple times, but the quadrilateral surface, in my mind, is useful primarily as a reduction aid. Once in a while, it's important, particularly for marginal impactions, to close the door and create a containment vehicle for elevated or depressed articular segments. But as a need for direct fixation in and of itself, it's rarely indicated. So this is the sequence. So the first thing that happens is the head is pulled back to close to its anatomic position. The sacroiliac joint is fixed after repositioning it. We can see a shank screw in the anterior column, a lag screw back into the intact component. The SI joint's been fixed. And then a sequence in which I typically use the plate as a preliminary, essentially clamp equivalent. And then secondarily, further refinement of the reduction utilizing a clamp through the plate. And then stabilization of the anterior column to the intact innominate bone. And then lastly, the posterior column fixation. Usually in this case, just 2 long screws initially. And then we have this screw again, which we've seen already, which is our screw medial to the joint. In this case, this was an in-out in screw. And then about 4-year follow-up with, you can see internal iliac fossa and external HO with, again, fixation of the posterior wall component from inside out. Okay, other patterns which I don't think are always amenable to that, extended iliofemoral. Michael should go over this in great detail in a bit. This is an atypical pattern for 2 reasons. One is we have essentially an ischiopubic segment with an inferior exit in the caudal portion of the sacroiliac joint. And then we have this extended anterior column component, which exits very far posteriorly. So without this reduction being perfect, this reduction can't be perfect. And so you have an obligatory surgical secondary congruence if you're lucky. So this was a younger patient, and this was an extended iliofemoral approach. So this shows the problem as far as looking at that displacement. And this was done through an extended iliofemoral, in this case, using a bone block for the medius pillar and a trochanteric osteotomy. Results at about 2 years. Now I have to apologize for some of the imaging for this. So this is the sequential ilioinguinal Coker-Langenbeck. I think I've only done this 4 times in my career, and most of these are remote. So this is one that's hard to see on the plain X-ray, and even worse on the 3D reconstruction since these were early. We can see this extensive anterior column component, again, very far posteriorly, a little bit of pelvic brim comminution, but the critical part of this was this segmental posterior wall component, which couldn't be addressed anteriorly. And looking at the axial cuts, we can see the separation between the anterior and posterior columns. And then we can see the beginning of this segmental posterior wall and the displacement. So this was done sequentially through an anterior approach first, and then turning them over to do a prone Coker-Langenbeck for management of this segmental posterior wall fracture. And then lastly, the extended ilioinguinal. This is again a pattern which we can see now. This segment is our intact innominate bone, and this is a large intercalary component of the innominate bone with the inferior or caudal portion of the sacroiliac joint, and then relatively modest displacements between the columns. In this situation, we can see that the exit point of the posterior column is actually quite low here, and here's our large intercalary component of the innominate bone, and not much displacement on the obturator. We do have these axial cuts which show this very large intercalary component, and this is our intact innominate bone, fortunately with still a stable sacroiliac joint complex. And so this is done, if you're interested, I think this is useful. I've done 6 of these in my career. They're rare, but they can be very useful. This is the posterior portion is an external iliac exposure, and then the patient is positioned in a 45-degree position. The table is carefully rotated to give you a supine ilioinguinal and a lateral approach to the ilium as well, almost lateral decubitus. So you can see the position of these screws. This is our lateral iliac exposure for this fixation, and then typical fixation for the more common both column components associated with it. So in summary, we have a wide range of fracture patterns, and they are demarcated by the pattern of anterior column extension, as well as caudal SI joint involvement, and rarely posterior wall components that are not amenable from an anterior approach. These are indirect reduction strategies that require an anatomic reconstruction from the periphery, since we never actually see the joint itself. So we start with the intercalary iliac segments, reconstruct the anterior column, and then the posterior column and the posterior wall. And the approach alternatives to the standard ilioinguinal or AIP / first window are the extended iliofemoral or sequential approaches, and rarely the extended ilioinguinal. With that, thank you very much.